Hi, my name is Tim Hamill. I'm an emeritus professor at the UCSF Department of Laboratory Medicine, and these are the start of two lectures I'm going to be giving on laboratory management. This first lecture will be laboratory regulations, and the second one will be on laboratory economics. I would suggest taking these in a couple of different sessions rather than all at once. There's a lot of terminology that we're going over, and really it's to get you used to hearing some of these terms and understanding what they are, and not only how they're important to good laboratory practice, but what are the regulations that require you to do some of these things. Okay. So, goals and objectives. You should be able to describe the various types of regulations and agencies that impact laboratory testing and their general components. You should be able to describe the basic components of CLIA 88 and what it does. You should be able to describe the differences between the various agencies and organizations that perform laboratory inspections, the nature of those inspections and how to prepare for them. And you should be able to describe something of the California specific laboratory regulations. So, first off, some definitions. Laws. Well, legislatures pass laws, either at the state or the federal level. It's the legislatures that actually create new laws. They may be called acts, they may be called codes, but it is a law. Then, once a law is passed, then some governmental agency is then tasked for writing the rules or regulations that enforce that law. So first there's a law, then there's the regulations, and usually there's a couple of years in between the law being passed and the regulations being written. Accreditation means certification. Typically this is going to be by some kind of professional organization, and it's a way to make sure that designated standards have been met by the accredited entity. A license is in something that either is done on a state or a local level, and that allows an entity to operate or engage in a business practice or occupation. So in California, laboratories are required to have a license. The license requirements imposes some restrictions on training of your personnel, the facility that you're going to use, competency assessments of your personnel, etc. And of course, as with any licenses, you're going to pay a fee, either on an annual or a biannual basis, to allow you to operate in that city or locale. So what are the federal agencies that impact laboratories? Well, the Department of Health and Human Services is a big agency, HHS. It covers the Center for Medicare and Medicaid Services. Understand that Medicaid is called Medi-Cal in California. We've got to be a little bit different. And under CMS is CLIA, the actual CLIA regulations. They own those. And the Office of the Inspector General, they're going to be involved in billing and fraud. And certainly, hopefully, no one you'd ever get involved with, and most laboratories never want to have to get involved with the OIG from CMS. They can be really, really nasty. The Food and Drug Administration is also under Health and Human Services, and they're predominantly involved in laboratory testing on the vendor side. So they're going to look at test devices and kits, and if they're FDA approved, then they can be marketed in the United States. A separate entity, the Federal Occupational Safety and Health Administration, or OSHA, is then involved in workplace safety, and certainly because of the nature of the work in laboratories, OSHA is intimately involved in all parts of healthcare, but particularly the clinical laboratory. So, CLIA 88, the Clinical Laboratory Improvement Amendments of 88. So there was a CLIA 67. That really only had to do with lab licensing, and interstate transport of samples really didn't impact the day-to-day operations of labs. But in the 80s, in response to concerns about unregulated labs and physician office labs turning out bad results and getting patients into trouble, and predominantly pap smear mills where a single cytotechnologist was forced to read maybe 200 slides a day, which meant they were missing cancers and women were dying of cancers. And there was a huge hue and cry and lots of articles in the newspapers and the news about this. And so Congress enacted CLIA 88 on Halloween in 1988. It took effect, however, as I said, regulations then had to be written. It took effect in September of 1992. So the regulations are all available for your review. It's in the Code of Federal Regulations. It's Chapter 42, Section 493. I've got a URL down at the bottom there that you can actually go and look at CLIA. I would highly recommend doing it just to kind of see how it's set up. Because whenever a question is asked about, is this within regulation, this is going to be the place you look to find out the chapter and verse about what the regulations actually say. So I wouldn't expect you to read it unless you're trying to put yourself to sleep, but it is a great reference for you as you get higher up in the laboratory management to be able to refer to that and know particularly what the regulations say. Okay, the first thing that CLIA did was define a laboratory. Because not all laboratories fall under CLIA, and we'll talk about that. So you can read through this. I've highlighted the important portion in yellow, and it's really examination of materials derived from the human body for the purpose of providing information for the diagnosis, prevention, or treatment of any disease. That's the bulk of it. Let's break this down a little bit and understand why certain laboratories aren't under CLIA. So materials derived from the human body. So it's got to be something from the human body. So it's not from animals. So veterinary laboratories do not fall under CLIA. Has to be from humans. And it is something derived from the body. It is blood. It is urine. It is CSF. It's a joint fluid. It's sputum. It's a tissue biopsy. It's whatever it is. It's a portion that has been taken from the patient and now is going to be tested. Okay. This means that things like taking a patient's weight, excuse me, listening to their heart, looking in their ear, measuring a blood pressure, all of those things do not require a sample from the body. Hence, they are not laboratory tests, and those places that do them, your physician's office, is not defined by CLIA as being then a laboratory. Okay, so it's very important to understand where that line is kind of drawn in the sand. So CLIA exempt laboratories, there are laboratories like vet laboratories that are totally exempt, but there are other laboratories that do testing on human samples but do not fall under CLIA. So laboratories operated by federal and state agencies, so Veterans Administration hospitals and laboratories, military hospitals and laboratories, public health laboratories, all are exempted from CLIA. They all have a CLIA look-alike that's very similar to CLIA, but you don't typically have one governmental agency, CMS, overseeing another governmental agency like the military. So they have their own CLIA look-alike. The Substance Abuse and Mental Health Services Administration, or SAMHSA, drug testing laboratories have their own set of regulations, and they fall under those. And these labs only really do workplace and legal drug testing. Laboratories doing only forensic testing. Well, it's from the human body, yeah, but it's not a live body, and it can't be used in treatment decisions. So laboratories doing only forensic testing, so down at the coroner's office, they don't fall under CLIA. Research laboratories doing testing on human samples do not fall under CLIA if the results of the tests are not released or used for patient care decisions. This is something that in an academic medical center I had to deal with all the time. There were lots of research labs, and certainly researchers who were physicians would say, oh, I could do this test in my laboratory and I'll get a result and I'll treat the patient. As soon as they do that, even for their own patient, that laboratory now becomes a clinical laboratory defined under CLIA, and the full weight of CLIA regulations fall upon them. So I had to really educate docs about if you're doing research, it's research, and you cannot use those results in patient care decisions. There are also laboratories in CLIA exempt states. So New York and Washington are states that have their own laboratory regulations. They are very stringent. They are more stringent than CLIA, and so they applied to the federal government and said, we don't need two different systems. We're going to only have one. And the government said, yeah, we've looked at your stuff. You're good to be CLIA exempt. California has tried this since the mid-90s. We're probably never going to get there, but just, yeah, they've talked about becoming CLIA exempt. I doubt that will ever happen. Okay, a little bit on just the CLIA certificates, because there's multiple types. Everyone thinks there's only one type. There's several. Certificate of waiver, and we're going to talk about what waive tests are. Certificate of provider performed microscopy procedures, and this also covers any waive testing done at the same location. So those ones above the line are things that might be done in a physician's office, group practice, maybe a hospital clinic, or somewhere in the hospital outside of the clinical laboratory where they're doing limited testing, typically right there while the patient is there to get an actionable result. Underneath the line, then, are what most laboratories are dealing with. And the first one is a certificate of registration, which really just means, hey, federal government, I'm opening a lab and I'm going to be doing testing and I'm registering with you. That is good for 11 months. During that period, the laboratory must be inspected either by CMS, which would give you a certificate of compliance, or by one of the deemed accrediting bodies like College of American Pathologists or Joint Commission or COLA, and we'll talk about those. And those would give you then a certificate of accreditation. The certificate of compliance and accreditation are equivalent. It just tells any inspector who you were inspected by for your last go-round. These are good for 2 years, and then you must be re-inspected and get another certificate to go on. Okay, so CLIA sets standards for all sorts of things, but we're going to cover test complexities, proficiency testing, pre-analytic, analytic, and post-analytic processes, quality control, personnel requirements, inspections, and quality assurance. A lot of stuff here. Take your time. Okay, test complexities. So I've already mentioned wave tests, and we'll talk a little bit more about those, but you're going to hear the term wave test and non-wave tests. So non-wave tests are two categories, and with a subcategory, moderately complex tests, subcategory provider performed microscopy, it's considered moderately complex, and high complexity tests. And the application of CLIA standards is all set up based on the highest complexity of testing performed in a given laboratory. So if you do 30 wave tests and one high complexity test, you're a high complexity lab because of the highest complexity tests that you perform. The FDA determines test complexities and sets those for all tests that are being marketed in the United States by vendors before they're marketed. So you know what level of complexity the test is when you're buying it. Couple of notes. You can get a list of all of those tests. You can actually search through and say, oh, this vendor, this test, what complexity level is it? And that URL gives you a search function. You can figure out what level of complexity test you're using. A couple of notes. In-house developed tests, we're going to be talking about those, are always considered high complexity. And if you have an FDA-approved test that then you deviate in any way from the manufacturer's instructions, you use a different sample type, you incubate it for a shorter or longer period of time at a different temperature, whatever, any deviation from the manufacturer's instructions, no matter what FDA said the test was waived. It was moderately complex. It is now high complexity. Once you've changed it, and the FDA says, okay, that is the same as doing it in-house, and you've got to do some additional stuff to show that that test works. Okay, go back here. So wave tests, Public Health Services Act said, wave tests should employ methodologies that are so simple and accurate as to render the likelihood of erroneous results by the user negligible. Okay, simple visual endpoint test type of thing, and pose no unreasonable risk of harm to the patient if performed incorrectly. So originally in 1992, when CLIA came out, there was a set of waved analytes that were allowed, and they're here: urine dipstick, fecal occult blood, ovulation tests, urine pregnancy tests, sed rate, hemoglobin, blood glucose, and a spun hematocrit. Those were the original analytes. And there were multiple different tests then that were wave tests that looked at these analytes, but those were the only things you could test for on a wave basis. That has expanded since 92, and currently there's 137. That may actually be 138 now. That are considered waved analytes, and there's literally thousands of tests that are available on the market to test these 137 different analytes. And if you want to look at what they are, I've given you a URL there where you can look at the entire list of analytes that have wave tests for them. And you'll see that there's a lot. I would argue that in expanding that list, we have dropped off the second requirement for wave tests, that they pose no unreasonable risk of harm to the patient if performed incorrectly. Some of these tests, if you did them wrong, I would argue actually could significantly hurt a patient, whether you got a false positive or false negative. And so for whatever reasons, the FDA, political pressure, whatever, has expanded the list of analytes, and we now have lots of wave tests. Okay, moderately complex tests. We've already mentioned provider-performed microscopy. These are microscopic procedures typically done near the patient on a sample directly taken from the patient, and typically by a provider. It's provider-performed. So physicians, nurse practitioners, physician's assistants, those kind of people who are authorized to perform this and have shown competency to do it, then can perform these tests. These are the different microscopic procedures they can do. So a potassium hydroxide, looking for fungal elements, say in a skin scraping, vaginal wet mounts or other wet mounts, urine sediment exam, qualitative semen, which means yes, there are sperm present and they move. That's all you can say. Ferning, which is where you take fluid from the vagina, and if there's amniotic fluid in there and you let it dry on a slide, it forms this nice little fern crystal pattern. It's called ferning test. Postcoital exam, pinworm exams, nasal leukocytes, and fecal leukocytes are all PPM or provider-performed microscopy. If it's not on this list, it is not provider-performed microscopy. This list has not changed since 1992. And so things like, oh, I'm a rheumatologist, I want to do crystal examinations on joint fluids in my office. Yes, you can do that. But you are now a high complexity laboratory. You have to get a CLIA certificate. You have to undergo inspections. You have to do everything that a high complexity lab has to do, because it's not on this list of PPM procedures. The other big category of moderately complex tests are ones you're going to become very familiar with, and these are the highly automated hematology, chemistry, urinalysis, coagulation testing. Anything where the test is very automated, where you're taking the sample, spinning it, throwing it on the instrument with minimal interaction on each sample, and you get a result, those are probably going to be considered moderately complex tests. And you can go and look to see if your particular test is on that FDA website and it is moderate or high complexity. Okay, so how did it tell between a high complex and a moderately complex test? Well, there's 7 criteria the FDA uses: the knowledge required to do the test, the training required, how much reagent material preparation is there, what are the characteristics of the operational steps, calibration, quality control, and proficiency testing, troubleshooting and maintenance, interpretation and judgment. So they score each one of those 7 things, a 1, 2, or a 3, total up the score, and a test with a score of less than or equal to 12 is moderately complex, and a test with a score greater than 12 is considered highly complex, and that's how the FDA does it. Okay, shifting gears here, we're going to talk about proficiency testing. Excuse me. It's required for moderate and high complexity tests initiated in a laboratory after 9/1/1992. That's when CLIA took effect. The laboratory must enroll in proficiency testing for each regulated analyte, and typically you're going to get 3 challenges per year and 5 samples per challenge. Now, these have to be from deemed proficiency testing providers. So the College of American Pathologists is a big one. American Association of Bioanalysts is another, but there's several companies that CMS has authorized to provide proficiency testing samples to laboratories. These are the regulated analytes are really commonly performed tests in virtually every laboratory discipline except molecular. Those came late, so those aren't included in the regulated analytes. And you can get a full list of those regulated analytes, a little handout there, CLIA brochure, which is a really nice walkthrough of proficiency testing. And I'd recommend just pulling it up and looking through it. It'd take about 5 minutes, and you can see what the actual regulated analytes are. So for all regulated analytes, you must get a PT from an accredited PT provider, and you get the samples, you do the test, you send back in the results, and you're graded. For all non-regulated analytes, so anything that's not on that list, then the laboratory still has to do something, and you must establish the accuracy of the test at least twice per year. How do laboratories do this? Well, the most common way is to use your proficiency testing vendor. They do proficiency tests for regulated analytes as well as for non-regulated analytes, and chances are you'll be able to buy a proficiency testing kit for any of the tests that are non-regulated, and it just makes it very easy for you to do this clear requirement. If there is no vendor a proficiency testing vendor that has a kit for your sample, then maybe you can find another lab that's doing the same test, because they're going to be in the same boat as you are, trying to find how am I going to manage this requirement of accuracy twice a year. And so you can set up to trade samples back and forth, say 3 samples from each lab twice a year. You test them, you send the results back, they say, yeah, you did very well, great. Okay, and then you document that and you have met this requirement. If you're the only lab doing a particular test, you develop this wonderful new test and you're going to do a lot of them. Another way you could do this is to simply hold back samples that have been tested. Obviously hold them at a correct temperature, frozen or whatever, so they maintain their stability, and then feed them back through the system periodically as blinded samples and see if you get the same result. Document that and you've met this requirement. Okay, here's a typical College of American Pathologists proficiency testing report back. So this was one for magnesium. We had 5 samples. Here were our results, the mean of all the labs that were performing the test, standard deviation. Here's the number of labs that were reporting results for this, the standard deviation index for your lab, how much you were off. Here's the lower limit of acceptability, the upper limit of acceptability, your grade, and you want all these to be acceptable, that's good. And then to give you this nice little graphic and show you, okay, for these samples, here's your 5 samples, and yeah, you bounced around the mean a little bit, but you're very close. That looks really good. Here's one where we've got a little more variation, but you're still far away from these edges, which is your limits of acceptability. And you want to see that all of your samples, or at least periodically, you're flip-flopping on either side of the mean. If you've got everything at one side of the mean consistently, take a look at that test. It's probably got a little bit of bias in it. If you have something where a few of the samples are edging up right next to the limits, then maybe you want to take a look at that test and make sure that everything's going okay, or you may need to recalibrate it or do something to get you back down to the mean of what other labs are getting for that test. Okay, laboratories must maintain a minimum success rate for their proficiency testing. If you're doing immunohematology, ABO and RH testing only, you must be 100%. No misses are allowed. If you're doing cervical cytology testing, you must be 90% successful. And for the vast bulk of the tests in the clinical laboratory, you must maintain a 80% success rate for all of the other ones. If you have 2 successive failures or 2 out of 3 failures, that means your test system is in jeopardy. And if you get a 3rd failure, you must stop that testing, go back, revalidate it, relook at it, do whatever you need to get it back in working order. And typically, most labs would do another set of proficiency testing, maybe an old set, and then look at the values and say, yeah, okay, now we're back on par, and now I've documented all that, and now I can resume that testing. Because all of these proficiency testing results that you send in, not only do you get a report back, but the government gets a report back. And they're looking at these, and they will know whether or not you have had proficiency testing failures. Okay, a couple of do's and don'ts. These are in that handout that I directed you to. You test only the primary system. We'll talk a little bit about that, but let's say you have 2 of the same analyzer. You designate one as the primary. That's the one you're going to test on and send the results back to. You actually take your second machine and match it to the first machine. Now, you may take patient samples and cross-test them to make sure they're the same, or you may get another proficiency testing set and do it on your secondary machine, or split the proficiency testing sample if there's enough of it and do them on both machines, but you only report from your primary machine. You rotate the PT among staff and shifts. It shouldn't be all done by the same person, same shift every time. You want everybody that's in the laboratory that's doing that test to at some point do a proficiency on it. Because you're not only testing the test, you're testing the personnel, right? You must test the proficiency test as you would a patient sample. So you don't double test it unless that's what you do with patient samples. You don't do anything different from the way you would test a patient. You follow up on any failures, document your findings and corrective actions, and CMS and CAP now are expecting you to go back and actually have looked at patient results since your last proficiency testing to see are there any really egregious results in there that were probably wrong because you came out of control and now you've turned out some results, and the expectation would be that you've contacted those patients and their physicians and told them that information. You do not refer proficiency samples to another lab, even if that's how patient tests are handled. So at UCSF, we had the hospital laboratory did total proteins, and we did our core laboratory did all of our protein electrophoresis. So most protein electrophoresis, you actually report the constituent protein fractions in milligrams per deciliter, but that requires knowing the total protein. We couldn't take and do the total protein at one lab with one CLIA and send it to the other lab with a different CLIA to do the electrophoresis because that was referring PT samples. Even though that is how we handled patient samples, you must not do that. A PT sample goes to one CLIA. It can only be used by that CLIA, and you may not trade it to a different lab with a different CLIA. You may not speak to another lab about proficiency testing results, certainly before the results go in, but it's also just bad form to talk about proficiency tests after the fact. And you should not test the PT sample in any way differently from a patient sample. Like, I'm going to test it 3 times and take the average. No, you would never do that. You caught doing that. And these are things that are zero tolerance with CMS. Labs lose their CLIA certificate, cannot perform laboratory testing in the United States if they do these things. It's zero tolerance, and do not breach those rules. Okay, we already talked a little bit about comparability of results, but if you have 2 of the same instrument or 2 instruments that do the same test, then twice a year you should look at, do they match up? So a great example is spun crits versus an automated crit, where it's really calculated from the RBC and the MCV. So you may want to run a bunch of spun crits on samples that you run in your automated instrument and see how they line up. That's just showing good laboratory practice that no matter which methodology I use, the results are the same. Same would be said for I have 2 of the same instrument, or different instruments. If they're giving out the same result, then we should match them up and make sure that those results are consistent between the instruments, so that it doesn't really matter which instrument I use to test a sample. You must have a system set up to detect unusual test results. So, and we'll talk a little bit more about these later, but normal range, critical values, and technical limits. Technical limits are the ones that are really key here, because you should have limits on things where that's just not a possible result if the patient is living. If you got a potassium of 2 or 10, that's not a possible result. It could be that the sample was adulterated. It could be that there was a lot of hemolysis. There's lots of reasons, but you should set up your technical limits to say this is outside of the realm of possibility for life or the nature of the assay, and therefore anything that falls out, I'm going to be very suspect on those. And you may just say this specimen was too hemolyzed to report a potassium out, because you're not going to report a potassium of 10. A doctor's going to freak out if you do that. So you need to have technical limits set on most of your quantitative assays to show that anything that comes out around that you're going to take with a big grain of salt and probably not even report it. Okay, test procedures. This is your procedure manual, and the procedure manual, there's lots of stuff about in CLSI and other organizations about how to write a procedure manual, but the procedure manual should cover the 3 phases of testing. So the pre-analytic, that's everything from the point of sample acquisition to testing. So it's venipuncture, it's correct tube type, it's correctly labeling the tube, big place for errors there. It's properly transporting the tube, especially if you're transporting it to some remote location. It's proper storage of that sample during transport and once it gets into the lab or before it's even transported. Are you doing it at the right temperature, etc. All the preparatory steps. So your centrifugation, how fast, how long, what kind of centrifuge you're using, refrigerated, non, whatever. That should be all listed under the pre-analytic portion of your test procedure. The analytic then is the testing itself. And so the test procedure should certainly cover the tests of setting up the instrument, doing the quality control, putting on a test, running a test, getting a result out. The post-analytic is in everything that happens after the test is run. And so that's, I need to repeat this with a dilution. I need to report this result. And then probably storage of the sample for some period of time in case you need to go back and retest it or do some other test on it. So the procedure manual should cover all of those. I won't go into that in any more detail. There's lots of information on procedure manuals out there. Test validation. Okay, CLIA says that every test placed into service after 9192 must be validated by the lab. So the FDA, if it's an FDA-approved test, the vendor has already gone through and done a huge amount of work to show that the test is accurate and precise and does everything well. But the laboratory must show that they can do the test just as well in their hands. And so for an FDA-approved test, you're going to look at accuracy, test precision, the reportable range, and at least verifying the manufacturer's normal range. If you're not going to use the manufacturer's normal range, and that's allowed, you must do a normal range study and establish your own normal range. One of the two has to occur. So those are the things that you would be expected to have documented. And when an inspector comes out, they'll say, what was the last 3 tests that you validated? I want to see those records. And they should be able to go through and see where you've done each one of those for an FDA-approved test. Now, let's talk a little bit about accuracy and precision because those are concepts that can get muddled a little bit. So here we're shooting arrows at a target and, I'm not very accurate. I'm not hitting near the bullseye and I'm not very precise. Those arrows are going all over the map. So this would be an inaccurate and imprecise test if we're talking in tests. Here's one where, my accuracy is getting better. Not very precise though. They're still kind of spread out. I want to get more where they're in a nice tight cluster. So this is an accurate but imprecise test. Okay, here's one where, wow, those are really nicely clustered. Pretty precise there. Your precision's great, but not very accurate, way off the target. So inaccurate but precise. And the one you're really shooting for is this one, right around the center of the target. Nice cluster, and that is an accurate and precise test. So when you think about it, whenever you're talking accuracy and precision, think about your target and kind of walk through and make sure you're understanding which one you're looking at. Okay, so we said what you had to do for an FDA-approved test to validate it. Well, what if I do what if I modify an FDA test? I change something. I use it on a different sample. I do different storage. I do different centrifugation, whatever. If you've changed the manufacturer's instructions, now it's a modified FDA test and you need to do more. Same thing would apply if you develop the test totally in-house, so-called lab-developed assay or lab-developed test. Then they're going to expect that in addition to the accuracy, precision, reportable range, and reference range, which I've already talked about, that you've also got data on the analytic sensitivity, the analytic specificity, and other performance characteristics such as stability, how it should be stored, any interferences, so are drugs going to interfere with this? Are there high levels of bilirubin going to interfere with this? You need to look at those. And if it's a modified FDA test, establish that that modification is really not change the test characteristics or the performance of that test. And all of those need to be documented, and an inspector will expect to see those. Okay, quality control. What's quality control? Well, it's monitoring tests or instruments by periodic testing of control solutions with, quote, known values. Now, we'll talk a little bit about how you set up those known values. But for qualitative tests, you're typically talking about a positive and a negative control. For quantitative tests, usually you're doing 2 or 3 levels of control, either a low, medium, high, or just low and high. The manufacturer will set the minimum frequency of running QC on their assay. And the FDA approves that, and therefore you must follow it, or you're deviating from manufacturer's instructions. Some may be every day you do the test, once every 24 hours, once every shift, whatever. For most highly automated tests, once per shift is probably the norm for most institutions, simply because if you get an out of control result and you have failed your quality control testing procedure at the beginning of a run, you're not going to test any patient samples, you're out of control. But you also need to go back, once you are back in control, you've tweaked the assay, you've rerun controls, I'm now in control, you should really go back and try and test all of the samples from the last point you were in control to when you went out of control. So a shift of 8 hours, you're probably going to have those samples available, unless it was a very small sample or something where you just don't have any left. You can probably go back and retest those if they've been stored appropriately. If you're doing it at longer intervals, then the ability to go back and test those samples is going to be limited. And so you're going to have tests that, I don't know if it's right or not. Typically with quality control, we're going to actually plot the results for each level of control for each test and watch those for shifts and trends over time. These are called Levy-Jennings plots. We're going to look at one. And you need to have down in your procedure what happens when results are out of control and what you need to do to check things. And when do you consider results out of control and when you consider a test to be in control, even though they're not exactly the value that you want to receive. So first thing is to establish control ranges. So the manufacturer is going to give you a mean and standard deviation for their control materials. But typically we use those only for their initial values. In most laboratories, you are going to, oh, gee, I'm running low on these set of controls for this instrument. Okay, I'm going to get some new controls out and before I run out, and I'm going to run those controls in parallel. It's a great way to do it. Say 10 times. If you could do it over 10 samples over a couple of shifts or a couple of days, and then compare that data, and you say, well, the old controls are still in. That means I'm in control, and here are the values for the new control. Then I can calculate a new mean and standard deviation based on the new control material data. How many repeats? 10 is probably good. 20 is probably better, but most labs are limited in terms of how long they can maintain old controls and keep them going. If it's a very expensive test, you might limit the number and say we're only going to test at 5. And you may periodically look at and say, oh, gee, I'm consistently on one side of the mean. That may mean your test has a bias in it, and you may need to tweak that test a little bit so that now you establish a new mean and standard deviation and can go forward. Some labs use a technique called moving averages, and this uses real-time average of patient data. So if you're doing 1,000 sodiums a day, okay, you could take the distribution of those results and look at the average. And that average, even though you're going to have real sick patients and they're out of range and all sorts of outliers, the average of a bunch of results is probably going to remain pretty stable as long as your assay remains stable. So you can watch those over time, usually on a weekly or bi-monthly basis or bi-weekly basis, and determine whether or not you might have some issue with your assay because that average is moving and it really shouldn't move very much. Here is a Levy-Jennings chart, and you can see we plotted for this is control number 2 for cholesterol, and we plotted each data plot, each run, and you can see that here we've got a mean in green, we've got 2 SD in yellow on either side of the mean, and 3 SD in red on either side of the mean. Usually you don't want to go outside of 3 SD. You don't really want to go outside of 2 SD, that's why these ones are flagged. Simply because your assay is getting quite a bit away from the mean. You want to stay typically within 2 standard deviations and bounce around the mean. You don't want to be on one side or the other. So awful hard to look at these, especially when you're looking at a month's worth of data at a time for shifts and trends. So So most manufacturers allow you to build in rules that will flag if you have exceeded that rule. In most laboratories, while you could set up your own rules, use what's called Westgard rules. And this is James Westgard. That's his picture there. And you can go to his website and read all about Westgard rules and quality control ad infinitum. There are tons of rules. You don't have to use them all. Most laboratories don't. Most laboratories pick rules that they think is appropriate for their specific assays. But some of the common ones are here. And you'll hear these things like 12S, 13S, 22S, 41S, 10X. What do these mean? Well, here's some examples. So this is a 1S rule violation, which means I've gone from being outside of the standard deviation here. I brought the thing back into control, but I'm still out one value out by 2 standard deviations. So I've got one value here. Let's say this is my low control, is out by 2 standard deviations. That may not be you're failing your control, but it's a flag to watch that. Okay. Here's another one. The 13S violation, more severe, and if you go outside by 3 standard deviations, your test is probably out of control. You should probably stop at that point, relook at the assay, get it back in control before you're testing any patient samples. Here's a 22S, and this is, I've got 2 values, outside of 2 standard deviations, and on the same side. Okay, my test may have gotten a bias into it, and so I'm running high. Okay, I may still be in control. This may be allowed, or it may be a partial flag for you, but you're going to watch those. Here's a 41S rule violation, and this is 4 samples on one side of the mean. And in fact, they've drawn in 1S lines here. I don't know why, but you've got four samples all on one side of the mean and all a certain amount out, and this is over 1 standard deviation out, and so that would be a flag that now you're running a bias and you need to look at that assay. Similarly, here's a 10X rule. 10 samples all on one side of the mean, bouncing around a little bit. I've got a bias in that, or maybe my mean and standard deviation that I set when I established these control values was incorrect. I didn't do enough samples to really capture a good mean and a good standard deviation, and this assay may just need to be recontrolled, new standard deviation and mean for the control material established so that you are back in control again. Okay, maintenance and function checks. If it's an unmodified FDA-approved test, you follow the manufacturer's instructions. That's all you're required to do. If it's a modified FDA or a non-FDA approved, so a home brew test, then you must establish maintenance and function checks that ensure test quality. All right, before we get into calibration and calibration verification, let's talk about some terminology here, and this can drive you crazy. So some definitions. The normal range. It's the mean of the normal population plus or minus 2 standard deviations. So really, if you did a Gaussian curve, it would hit the central 95% of the values from a normal population. So automatically, 2.5% on the low end and 2.5% on the high end of normals are going to be considered out of range. That's why very minor deviations from normal probably don't mean anything. We know there's normal people out there that run those levels, but we had to get a range. We took the central 95% confidence interval, and that's our normal range. That's different from the analytic measurement range, or AMR. That's the range of results that are achievable on your instrument without sample dilution or concentration. And typically the AMR is going to be wider than your normal range. So your normal range is 10 to 100, your AMR is 2 to 200, whatever. Typically the AMR is bounded by the limit of detection and the limit of, on the low end, and the limit of linearity on the upper end. And we'll talk more about those. The clinically reportable range, the CRR, is the range of reportable values if you were able to do sample dilutions or concentration. Mostly it's going to be sample dilutions. I've got, I'm off scale. I'll dilute the sample tenfold, rerun it, multiply that result by 10, and now even though I'm well outside the analytic measurement range, I can still report a result because I take the dilution into account. So that's the reportable range. That's typically going to be set by your laboratory director as how high do I want to define this test. In some cases, clinicians may come back and say, you're always giving me this greater than thing. And you go, well, that's the limit of our clinically reportable range. Well, that doesn't tell me I need to do so-and-so, can't you? And sometimes you've got to work with them about where to establish that clinically reportable range so that it keeps your clinicians happy. Okay. Limit of blank, limit of detection, limit of quantitation, and limit of linearity. Okay. Limit of the blank. So these are values produced on your analyzer if you just took the diluent alone and ran it. It's essentially the noise in the assay. And so you run it, the blank 10 times, you get some value out of it. You do a standard deviation, multiply that by 1.64, I believe it is, and that is the limit of the blank. That'll give you a value that says, below that, meh, you're not detecting anything. The limit of detection is the lowest amount of analyte that the assay can reliably detect. And typically, the limit of detection is going to be higher than the limit of the blank on almost all assays. So it's really that amount of analyte that I can reliably detect, and it always gives me a positive, readout. It may be quite variable, and that's where we come into the limit of quantitation. That's the lowest amount of analyte that the assay can reliably quantitate. So if you ran the same sample over and over again, you get pretty much the same answer each time. And again, your limit of quantitation may be your limit of detection, or may be higher than your limit of detection. It depends on the assay. The limit of linearity then is the highest assay signal, the highest result that you can get out, where the relationship between the concentration and the signal is constant. Okay, that's the linear portion of the curve. So let's look at these a little bit. So I just drew this up real quickly. So here we've got a concentration on the x-axis. Here's the output of your instrument, and then here's your values, and you'd plot them along and you do your best fit line, and hopefully this is about at a 45-degree slope. And so your limit of the blank here, I'm just testing diluent, and I'm constantly getting some concentration, even though we know it's only a blank, it's noise. So that's the limit of my blank. Here's my limit of detection. This is where I can reliably detect that analyte in that sample over and over again. I run it 10 times, I still get a positive on each one. May not be very accurate, but at least I still get a positive. That in this case, I'm making the LOD equal to the limit of quantitation, that I'm able to quantitate it reliably, usually at the 95th or in some assays at the 99th percentile for accuracy. Now here's my linear portion, and this means I've got a constant, not necessarily ratio, but a constant comparison between concentration and signal. And then at some point, I'm going to lose that. And here, okay, now past here, it's not linear. And this could be a straight line. This could go this way. It could be a curvy line. It could do anything. It just means above that, I don't know how signal refers to concentration at all. I can't, there's no calculation I can do to bring it in. That's my limit of linearity. And so that defines that, and my limit of detection define my analytic measurement range. This is where I can measure. Now, my clinically reportable range could be much higher, but that means I'm taking something that's way up here and I'm simply diluting it down so I can get within this AMR and then multiply the result out by the dilution factor and get a reportable result. Okay, so here's some examples. So here's albumin. Normal range 3.5 to 5. The AMR for this test is 1 to 6. And my clinically reportable result is 1 to 6. You typically don't do any dilutions on albumin. You never see hyperalbuminemia. That just doesn't occur, unless you were super dehydrated. And so the CRR and the AMR are the same here. Here's ALT, normal range 13 to 69. I can measure from 1 to 1,000, and I can report from 1 to 15,000 because I can dilute it up to 15 times in this assay. And typically, it's your lab director who's going to determine how much dilution you can do on any test. Cholesterol, 100 to 200. AMR is 50 to 235, but with dilution, I can report from 50 to 975. Creatinine, 0.4 to 1.1. My AMR, I can measure down to 0.1 and up to 14, and I can report from 0.1 to 28. And that's going to be the limit because I'm only allowing in this lab to dilute twice, do a single dilution in order to get a result. So those are some examples of the differences. Okay, after all that, now test calibration. So CLIA requires that you do test calibration, and that is adjusting the test system or instrument to establish that correlation between the test output and the analyte concentration. Typically, once you've got the test set up, you're going to use a set of 3 to 5 calibrators, and these are very expensive. They've been tested multiple times. They have known values that span most of the analytic measurement range, including the limit of detection or very near to it, or the limit of linearity or very near to it. I say very near to it because in a lot of laboratories, if I say, gee, my limit of linearity is at 100, but I've only got a calibrator that goes to 90, I probably should stop at 90 and just not report anything at 100, even though I think the assay can do that, simply because I don't have anything that controls out there. I can't calibrate the test out there. Similarly, on the low end, gee, I think the assay can go down to 5, but I've only got a calibrator that goes down to 7. I probably shouldn't be reporting under 7 because I really don't have anything to test it down there. You have to go through a lot of machinations to be able to test those little ins on anything. So you want to get calibrators that almost, if they don't span the analytic measurement range of your instrument, get as close to it as you can. You can use calibration during the validation procedure to establish your linearity, your accuracy, and your precision to some extent. Not all of it, and you should have other studies that show these same things, but test calibrators are a good way to actually initially establish those. Calibration verification then, so I've done the initial calibration when I validated the test, but every 6 months, or after a complete reagent change, or after major maintenance, or if my controls are showing a shift or trend and I have to bring it back into calibration, then I'm going to do calibration verification, which is fairly similar to doing the validation, but we're going to verify and redo it every 6 months or so. Okay. Critical test values, this is in the post-analytic phase. So these are values that are outside the normal range to a degree that may constitute an immediate health risk to the individual or require immediate action on the part of the ordering physician or provider. So an example would be a high or low potassium, low hemoglobin of 3, positive blood cultures, bacteria in a CSF sample. All of these are considered very high risk and require that you notify the appropriate clinician or staff to be able to act on those results. You don't just throw them out in the computer and hope someone looks at them. Laboratories must establish their own critical value list and the procedures for notification of care individuals when critical values are identified. ASCP, CAP, other labs, and providers can all give input on what those critical values should be, and each institution should have their own critical value list that's approved by not only by the lab, but by the medical staff. Rapid, direct communication to a provider should be documented in the lab record whenever a critical value is identified. And by direct, I mean you're talking to them on the phone or you're talking to them face to face. Don't leave it on a fax. Don't leave it on an answering machine. You don't know when those are going to be looked at or listened to, and you don't want a patient dying because, oh, yeah, well, I put it out on a fax. Well, no one read the fax, and so no one did anything about it. Now you're in a lawsuit because the critical value wasn't reported appropriately. Direct communication. Labs are now coming into looking at, we did this at UCSF, things called subcriticals. And these are results that may not require immediate provider notification, but it would certainly be detrimental if the provider didn't know about these at some point. So things like a positive hepatitis test, a positive HIV serology, a positive culture from a wound or something like that. Each laboratory can look at those things that they think are, gee, I would never want someone to miss this. And so it may just be, hey, I'm going to report it my normal way. That might be fax, that might be a hard copy, that might be computer. But within 24 hours, I'm going to follow up and say, hey, did you see that? Did you note that there was that kind of bad result there? I wanted to make sure you know about it. Sometimes clinicians get grumpy about these things, but I'll tell you, it has saved lots and lots of lawsuits to make sure that clinicians are actually looking at the results of the labs that they have sent out. Sometimes they'll go on vacation and no one looks at anything for a month. So you really want to make sure that some things are just not missed. Okay, testing records. Testing records sent out by the lab, and this is whether it's in hard copy or fax or on a computer system, should have patient identifiers on it, their name, their medical record number, date of birth, sex, age sometimes, the accession number for the sample. That's how you can look it back up in your system, so did anyone call up and say, hey, I got a funny test here. Can you go back and look at that? The date and time the sample was collected. The criteria for rejection if the sample was rejected. This was leaking, and we didn't even test it. This was markedly hemolyzed. I can't test it if it's hemolyzed. And so you would say the result of the test would be rejected, gross hemolysis. The date, time, and place where testing was performed. So what lab, what day, and when. And the, quote, name of the individual who performed the testing. Usually in most computer systems, that's not going to be your name. It's going to be some code number that you are assigned by the laboratory so they know, oh, 325, that's Tim Hamill. Tim Hamill did that result. So if there's a problem with it, you can go back and talk to Tim and determine, what was going on when that test was reported. Record retention. So every state and every entity may have different requirements for how long you need to retain all your records. So here's a chart that we made out at UCSF that people could follow and see, well, what was the most stringent? So Medi-Cal in California is pretty stringent. It's 3 years for most everything. The procedures, your patient reports, your test records, your preventative maintenance, all of that stuff. California, actually, it's 2 years on most of those things. And then for federal, it's 2 years, except when you get down to immunohematology and blood products, and then it's 5 years. So you need to know, I need to not only follow California rules, but I also need to follow Medi-Cal rules, and I also need to follow federal rules. And so whoever has the most stringent rule is the one you need to follow. Okay. Personnel requirements for CLIA for all laboratories performing highly complex tests. You must have a director, a medical director, a technical consultant, a clinical consultant, a general supervisor, and you must have some testing personnel. Now, theoretically, I, as a pathologist, could open up a lab in my garage, and I could be the director, and I can be the technical consultant, and I can be the clinical consultant, and I can be my own general supervisor, and I could do all the testing. But for most laboratories, you're going to have different individuals for each of these. Now, the director may assume the director, technical, and clinical consultant roles, and then you have general supervisors and the testing personnel. Each of these has explicit requirements. So by and large, a director must be a pathologist. Other physicians can be directors, PhDs can be directors, but they require specific training and skill levels. and your state may require different things. In New York, if you wanted to be a director of a lab that does chemistry and hematology and urinalysis, then you must pass a director's exam for chemistry, hematology, and urinalysis. Luckily in California, I didn't have to do that, although I'm trained in all of those disciplines. Okay, through CLIA. Let's go to laboratory inspections. So as I mentioned earlier, inspections are required every 2 years. There are federal and state CLIA inspectors. These are typically done through CMS. There is an office down in Los Angeles that they can field a CMS inspection team. And there are labs in California that are inspected by CMS every 2 years. But most labs are going to be inspected by one of the accrediting organizations that have been deemed by CMS to perform these. So College of American Pathologists, CAP, Joint Commission, TJC, the Commission on Laboratory Accreditation, COLA. They predominantly do physician office labs. The American Association of Blood Banks, or AABB, and lots of places will, if you've got a laboratory and it has a blood bank, you'll get both, say, College of American Pathologists for the lab and blood bank, and an AABB certification too. It's double good housekeeping seal. The American Association of Laboratory Accreditation, A2LA, they look at both CLIA and ISO regulations. So ISO is a different regulatory thing that's international Standards Organization. The American Society for Histocompatibility and Immunogenetics, or ASHI, they do HLA testing labs. And the American Osteopathic Association, or AOA. So these are the deemed organizations. I think there may be one more that came in from Denmark that's Nordansk, but I don't have anything on them. So maybe if you hear their name in the future, you'll know that they're another deemed agency. If you look at, this is back from 2018 data, how many labs are inspected by each, you can see that COLA is a very significant number of labs, but most of those are physician office labs. CAP and Joint Commission do the vast majority of commercial and hospital laboratories, and then AOA, AABB, and ASHI do their small segments of their niche labs that do very specific testing. Okay, let's talk about CAP, College of American Pathologists. Their inspections are based on general and section-specific checklists. And so you have this thick wad of paper that goes through literally hundreds of questions. For each question, that you can pass, or you can have a phase 1, which is a minor, or a phase 2 deficiency if you don't pass that question. And then inspectors can also make recommendations based on their review of your operations and say, hey, we do this at our lab. You might look at doing this at your lab. It's a good idea. We've prevented a couple of blah, blah, blahs, whatever. The CAP inspections, one thing I liked about them is that you do get to speak to people from other laboratories. So the CAP inspections are performed by staff from other CAP inspected laboratories. And if you are CAP accredited, you must field an inspection team, usually annually or every second year, to go out and inspect somebody else. So it gives you a chance to go out and see how a different lab runs. Just like when they come into you, it should be a collegial interchange of, oh, hey, you've got this problem? Yeah, I've been trying to solve. Oh, here's how we solved it. And you can share information back and forth. A great way to network. Inspections have to be unannounced. That came up about a decade ago now, that the inspectors just show up. You know kind of when they're going to show up because you have your inspection window. It opens up 3 months before your CAP certificate expires. So you know that they're going to probably come in that window. They don't have to. They could come earlier. They can't come later. But you just don't know within that 3 months that they're going to come. It can be problematic if you got staff that want to go on vacation. Joint Commission used to be called JACO, and now it's the Joint Commission. Their inspections are based on standards, similar to the checklist questions, except they're just more broad. Do you have a procedure manual? Okay, and then they're going to look through the procedure manual to see if it's got all the thing, whereas CAP has a specific question on each portion of the procedure manual. They are performed by Joint Commission staff inspectors. These are paid inspectors. And the standards are open to interpretation by the inspectors. So one inspector may come in and say, hey, that's fine. Now, what you're doing there is just fine. The next inspector may come in 2 years later and go, no, don't like that. Going to cite you on that one. Same thing. All you can do is roll with it at that point, and try and determine what they want you to do to bring it into compliance with their standard. Joint Commission uses something called the tracer methodology, which I think is a really interesting way of looking at things. And basically, you follow a sample from the point it comes out of the patient to the point where the result is transmitted and the sample is then either discarded or stored. Again, inspections are unannounced, just like with the College of American Pathologists. Those are the only two I'm going to cover in terms of inspection agencies, because if you're working in a hospital environment, these are the ones that you're going to see almost universally. The other ones would be very unusual to see in a hospital laboratory within the United States. Okay, done with CLIA. Let's talk about Occupational Safety and Health Administration, or OSHA. And if you think it's a small town in Wisconsin, you're definitely in trouble. So it was created in the Occupational Safety and Health Act of 1970. And there are OSHA standards, and these are rules that must be followed to ensure safe working conditions. The rules are established by a 4-step process. OSHA identifies that there is a hazard in the workplace that poses a risk. They demonstrate that the standard, if used, would significantly diminish or eliminate that risk. OSHA will select the best protective exposure limits, if it's chemicals or biohazard, whatever, that is economically possible. So what that means is they're usually going to take the most expensive, but they'll try and say, well, you don't need to use a full respirator mask, in this situation, and N95 is fine. OSHA seeks cost-effective ways for most employers to meet these exposure limits, but once they've established their standard, that's what you're going to have to do. So OSHA established universal precautions, and you can read through these. They're pretty much standard in every institution. All blood and body fluids are to be treated as infectious. You use barrier precautions. You wash hands immediately if contaminated. You remove gowns before leaving the lab. Use special precautions with any sharps. You do not recap needles. We're going to hear that numerous times. You dispose of sharps in puncture-resistant containers. Special devices for resuscitation. That's not for the lab. Biosafety cabinets when performing procedures with droplet formation. Don't mouth pipette. Decontaminate your work surfaces. Decontaminate your equipment. Use standard sterilization procedures, and dispose of your infectious waste properly. That's all universal precautions against biohazards. OSHA sets up engineering practices to try and mitigate risks. So things like self-sheathing needles. When I first started, we didn't have these. And so now there's a whole slew of self-sheathing needles that prevent needle stick injuries, and we don't like people bending needles. Sharps containers, plastic, rigid, puncture-proof sharp containers. When I was a medical student, they were cardboard, thin cardboard. Needles stuck through them really easily. We had 2 students in my class that got punctured by throwing away containers that were full of needles and getting stuck by one that was sticking through the box. Red bio-waste bags, just making them red. So you know that this is biohazardous material and needs to go in the biohazardous waste stream and typically is going to be incinerated. They also establish work practice controls. These are very similar in terms of the lab to the universal precautions. So you don't eat, drink, or apply cosmetics, contact lenses in areas where potentially infectious materials exist. No food or drink in specimen refrigerators. Provide and require the use of hand washing facilities. Routinely check and decontaminate equipment. Wash hands after glove removal. Don't recap or bend your needles. No mouth pipetting. And placing contaminated materials in leak-proof containers for shipping and disposal. So those are considered work practice controls. So OSHA looks at we're going to make some general requirements, universal precautions. We're going to have some engineering controls to further limit exposure. We're going to ask people to do certain things, work practice controls within the laboratory to further reduce the risk of any biohazard contamination. PPE. So you use PPE if exposure risk remains after the engineering and work practices controls are implemented. So if you're working in the lab, and it's up to you, but I would recommend wearing your PPE, certainly a lab coat, gloves, eyewear if necessary, if there's anything, or working behind a shield. And PPE is considered appropriate only if it prevents infectious material from reaching your clothes, skin, eyes, mouth, or mucous membranes during use. It must be provided at no cost to employees. If you asked for it, you should get it. They should not charge you for it. And it should be clean, laundered, and or replaced as needed, and cleaned and laundered on site or through a specified contract with some agency that does this cleaning. They don't want you taking this stuff home and washing it in your clothes washer with your family stuff. Okay, so that's PPE. If you're working with chemicals, you must have a chemical hygiene plan, and this includes engineering controls. So things like, I don't use glass bottles. I use bottle containers. I use carriers for heavy stuff. I have eye washes, respirators, and safety showers in case I get splashed. I have appropriate PPE, which may mean I need a full apron that's impervious to chemicals, a mask, a face shield, long gloves, whatever. I'm going to have signage on all my areas that contain chemicals to tell me what's in those areas and what's the flammability, biohazard, and radiation hazard of any of them. I must have a waste disposal program for all my chemical waste. I must educate my staff on all of this program, and you have to have the material safety data sheets, or MSDS sheets, available for each chemical that you have in the laboratory. Mostly laboratories have gone away from bulk chemicals, and you're using just chemicals in the reagent kits, but those will have MSDS sheets associated with them, and you have to keep those around or have those available. So in case someone gets it on them or gets it in their eye, you'll know how to handle it. Okay, that's OSHA. Food and Drug Administration. So I said that the Food and Drug Administration doesn't really look at the lab specifically. They have oversight of instruments or test kits that are marketed to labs for testing. So it's a pre-market approval process. So vendors like Abbott, Roche, they all go through this before they can market a test or an analyzer in the United States. They must be FDA approved. Now, if I do a home brew test, and I could do that test in-house for somebody else, but I can't take that test and put it in their lab and let them do it. That would be two labs crossing. I've essentially shared the test, and now I fall under the FDA. In addition to total assays, the FDA looks at things that they call incomplete assays. So these would be bulk reagents. So if you're using, sodium hydroxide, is it of the sufficient quality to be used in your testing? And so they're going to have some regulations about, standards of the quality of reagents that you use. Then there's things called analyte-specific reagents, or ASRs. One of these I can give you an example of flow cytometry reagents or molecular diagnostic probes. These are for a specific test, for a specific purpose, but it's just the reagent. It doesn't necessarily say which instrument you're going to be using it on. So like a flow cytometer, I have to validate the flow cytometer based on the ASRs that I'm using on it, because the vendor who provides me those reagents only says, well, it's for T4 cells or CD4 cells, but you are going to have to do your own validation of these. The FDA does not require the vendor to validate those in the same way that they validate a full test. The lab has to do it. And as we've mentioned before, the FDA determines those CLIA test complexities and lists whether it's a wave, moderate, or high complexity test. Okay, California regulations. So mainly these are in Business and Professions Code Section 1200. Don't go and look at it. There are some in the Health and Safety Code, mainly around HIV testing. particular items for laboratories under California regulations are the personnel standards. So clinical laboratory scientists must be licensed in California, must have gone through a training program, must have passed a certification examination. Medical laboratory technicians, very similar. Non-licensed personnel, it specifies what non-licensed personnel can and cannot do in a clinical laboratory. And basically it comes down to you can't do anything that requires judgment. So example of that is when I first started at UCSF, they had a giant graduated cylinder, and they would take 24-hour urines and pour it into the this thing that could hold 3 liters, and they would measure the volume of the 24-hour urine because that's important for determining the quantitation of material in it. But because you're reading a meniscus and that requires judgment, California said, no, you can't do that. You have to have some other methodology that doesn't require judgment. So the lab director at that time, Dr. Cohen, bought a very large digital scale. And basically, we would set the jugs on the scale. We had tiered it already. And then all they had to do was read the weight off of the scale. And for all intents and purposes, weight is close enough to volume, 1 mil, 1 gram. And so we could substitute the weight for the volume in those circumstances. Otherwise, you would have a licensed personnel having to measure it by eye. Similarly, though, taking weight, if I took a triple beam balance scale and I was using weights and making sure it was okay, it's zeroed, great, okay. No, that's judgment. So using a triple beam balance scale would be outside of the scope of practice for a non-licensed personnel. That would have to be performed by a licensed individual in a clinical lab. California does allow auto verification, which means if a result comes off an analyzer and it meets certain criteria, like it's in the normal range or it's not a critical value, then the system can auto verify that. It no longer is a requirement that every result be looked at by a CLS or an MLT before it goes out. Laboratory license requirements for all laboratories, unless it's a laboratory that's only doing wave tests and then they just register with the state, but they don't have to have a license in California if you're only doing wave tests. Doing provider-performed microscopy, need a license, but not for wave tests. California laboratory oversight, well, there's 2 areas, licensing and certification. That takes care of your licenses as CLSs or MLTs, as well as laboratory licenses. And then there's laboratory field services. These are all under the California Department of Public Health, and they are the ones who would come out and do an initial inspection prior to issuing a license for any new laboratory. Okay, other special California regulations. California says that any sample referred outside of the state for testing can only go to a laboratory that is licensed by the state of California. And most big commercial labs are, but there's lots of labs that are not. And I would say this is one of those regulations that's really never enforced, because if I told them as a director, look, if there's only one lab at some academic institution that does this test that a patient in California needs, and I must send it to them and they do not have a California license, I'm sending it to them. And you could take me to task on this regulation, but I think in the best interest of patient care, this should be going out. Really, this is aimed at laboratories that are doing lots and lots of reference lab testing to make sure that they are California licensed if they're receiving lots of California samples. Laboratories may be inspected by laboratory field services if there's any complaints or before they get their initial license. Phlebotomists are required to be certified, so undergo training and certification in California before they can do clinical phlebotomy. There are HIV and infectious disease reporting requirements, so if you get an anthrax in the microlab, you have to report that. I believe it's within 4 hours to the state. California still does require consent for HIV testing, although it's implied consent now based on the physician order. The physician is supposed to document that they discussed it with the patient and the patient agreed. In the past, you used to have to get a signed piece of paper from the patient before you could do an HIV test. Who can order tests in California? Only those people in California that are authorized to use test results in clinical care can order tests. With few exceptions, patients cannot come into a lab and order a test on themselves. There's about 5 or 6 different tests that are deemed orderable by patients on their own, such as a pregnancy test or a cholesterol test, occult blood, something like that. But they're very, very limited in California. Some states, like Arizona, allow patients to order anything that they want at any time. And laboratories make a lot of money because they charge cash on the barrelhead for doing that. But in California, we limit that. Similarly, we limit who results can be released to. And if a patient calls in and says, hey, I need to get the results of my test, really you should tell them you need to contact your physician or you need to contact our medical records. The laboratory should not be giving results out directly to the patient because you cannot give the additional information that the patient needs to interpret that test based on their clinical symptoms and their well-being. That's up to the physician to do. So usually our process at UCSF was patient calls in and say, hey, I need the results of my blah, blah, blah test. You need to contact your physician. We have the results. They've been sent to he or she, and you need to talk to them about it. I cannot release the results to you directly. Okay, that's it for regulations. That's a lot of stuff. I believe you have my email, so if there are any questions or things that are not clear about any of this, please don't hesitate to drop me an email, and I'll answer it to the best of my abilities. Good luck, and we'll see you